I'm Dr. Sandeep Desai, diabetologist at Advanced Diabetes Care, Valsad, and I have been practicing since almost 25 to 28 years in this field, and we are giving comprehensive diabetes care at our center.
How does Imeglimin fit into your regular practice with the current landscape of T2DM treatment options? Kindly share your experience.
Okay, so basically, we have multiple drugs available for diabetes. We all know some are acting on the insulin secretion, some on the resistance, some at the kidney level, GI level. But now this Imeglimin has been available since a few years with a novel mechanism of action. They mainly act at the mitochondrial level, which is a cellular level, which we have never explored. And so it is not only improves the insulin sensitivity, but also increases the insulin secretion. And so it acts at both the level. And hence, like metformin, it will improve the reduce the hepatic glucogenesis. It will improve the glucose uptake also, and also it will act on the pancreatic beta cell and improve the insulin secretion. So it will act at both the level, which is almost not done by most of the drugs which are right now available. So this is what we can say, and so probably it will be a good armamentarium to the existing therapy which we are already giving.
In what specific patient populations do you see the greatest benefit of using Imeglimin?
Yeah, so when to use, in which patient, that is always a question practically for every clinician. Simply, if you say, probably right now it is not the first drug of choice, but if a patient is not controlled on multiple drugs and the patient is not ready for insulin, this is one drug which is a no nonsense kind of drug which we can add with having synergistic action with most of the drugs, not having any adverse effect in terms of not interacting with other drugs, and at the same time giving the additional benefit of both the mechanism, insulin secretion and sensitivity. At the same time, if there are certain patients who are not metformin, they do not tolerate metformin at all. Even 1000 milligram metformin and they will throw tantrums, they will have GI side effects. So these are the drugs which you can reduce the metformin to the minimum, or probably sometimes you have to stop metformin and there we can give this drug. And of course, on addition to insulin also, if there are multiple drugs, insulin, we can give benefit of this drug to the existing therapy.
In recent time, Imeglimin sustained release formulation with Indian study has been launched in India. What is your opinion on that?
Yeah, any sustained release formulation will have two benefits. One is the longer duration of action and another is less side effect. So this is what it is. We have seen it practically, and almost the efficacy remains the same. So efficacy remains similarly. We have metformin since so many years, and we have sustained release. So there are patients who, as I said again, those who are intolerant, or you can reduce the dose of metformin, you can add this Imeglimin and give the benefit of the sustained release formulation to these patients.
How does Imeglimin compare to other hypoglycemic agents in terms of safety and efficacy? Kindly share a real-world case, if any.
Efficacy, yes. We have seen multiple patients who are on 3 to 4 drugs. Still, the A1C is around 7.7, 7.8. Still, there is something which is missing. What we do is we usually, these are the patients wherein insulin might be one of the choice. The patient is not ready to take the choice. There are certain patients who are on dapagliflozin, but they are not tolerating because of the GU infection. We have to stop this drug. So that is where this drug comes into play. So we cannot give DAPA because of some side effect. We cannot give PIO because the patient has some cardiac problem. There is some extensive weight gain the patient has. That is where Imeglimin, which is a very safer drug in terms of GI tolerability, the issues are not there, other side effects are not there. You can add this drug, which we have done practically, and we have seen that almost comparable efficacy which we can match with the other drugs. At the same time, negligible hypoglycemia and very less GI side effects. Sometimes what we do is, certain patients are not, we start with 500 milligram BD and then we increase in the next visit to 1000 milligram BD. The patient easily takes it and without any major problem.
How does the mitochondrial targeting mechanism of imeglimin influence its clinical use?
So this is one thing which is novel with this molecule. We have been using multiple drugs, as I said. This is one mechanism which is acting at the mitochondrial. So it's a cellular level mechanism. So what is happening? Probably we are not able to understand, but they are improving both the areas, the secretion as well as the resistance and the metabolic health, which is there at the mitochondrial level where there is a dysfunction in diabetes, that is also improving. So it has a pleiotropic benefit, which probably research and future will say that it is going to benefit in terms of cardiovascular health also, and the overall metabolic health will improve because of the mitochondrial function which is improving at the cellular level.
What are the key safety and efficacy findings from clinical evidences on imeglimin that clinicians should be aware of?
As I said, nothing much. Efficacy is almost good as any comparable with other. Of course, sulfonylurea and insulin and pioglitazones are molecules which are highly effective and in terms of A1C reduction and FPG, PPG. But most of the drugs are modest efficacy, which this drug also gives in combination as well as monotherapy. And safety, as I said, it is good. Tolerability wise, it is good. The GI side effects are less, and the other benefits which are giving it seems to be, in terms of safety and efficacy, reasonably good molecule to use. Even in combination with other drugs, it is a very safe drug.
Do you believe that imeglimin has the potential to change the future landscape of diabetes treatment?
Yes, again, I would reinforce that the novel mechanism which it has, the mitochondrial function which it improves, it is difficult to prove it in terms of the clinical benefit. But right now we are seeing the efficacy in terms of the FPG, PPG, the A1C lowering, the less side effects, and we are happy. But probably the mitochondrial function improvement at the level of the other organs will help to overall improve the metabolic health and what we are talking about, the cardiovascular health also. So that is probably a research thing which is going to come in future, and we are going to have this benefit of this drug which will have an overall pleiotropic benefit rather than just improving the glucose control. So future seems to be good for this molecule.
Any other key point or take home message you would like to share apart from this?
Nothing more. I've already mentioned everything, but probably whenever, as I said, again I will mention that if you are afraid of using 1000 milligram, you can start with 500 milligram 1 BD, and you can increase the dose to 1000 after 15 days also, or the next visit of 1 month. And most of the patient will not mind, or in terms of the efficacy, in terms of the safety and the GI side effect which the patient is worried about, any other medication. You can use it with all the drugs, even with insulin. So there is no other interaction anywhere. Probably you have to start using it in patients who are on 1 or 2 drugs, who wants another third drug, and there we can use where DAPA sometimes is not tolerated, or where, as I said, PIO is contraindicated. That is where this comes as a third drug probably in the armamentarium.